Run. Let's go. Get rid of this.
Hi, I'd like to welcome all of you to the NFOSD webinar series. My name is Ed Steger, and I'm the president of the National Foundation of Swallowing Disorders. I'm also a head and neck cancer survivor. I'm going to take a minute to tell you a little bit about the foundation before introducing tonight's keynote speaker. So the mission of the foundation is to provide direct patient support, and we do that through referrals to qualified speech-language pathologists, physicians, and medical teams around the world to provide education, such as tonight's webinar, to increase swallowing disorder awareness and to promote promising research. And that research has included anything from helping to fund phase 1 clinical trials to a paper that we published that we provided seed funding for about 2.5 years ago, that was published in December, that looked at the cost burden of dysphagia over a 5-year period for inpatients in the hospital. So I encourage you to go out to our website, look at the material we have there. It's really quite comprehensive, and we're getting 30 to 40,000 website hits per month. Our webinar series is sponsored by a unrestricted educational grant from Bracco Diagnostics. All of our webinar speakers have volunteered their time, and we're very thankful for that. During the webinar tonight, you will be muted, but there's a blue question mark on your screen, and we really encourage you to ask questions during the webinar, and Lisa Blumenfeld, our speaker tonight, will answer those questions. Lisa is a co-director of the Moores Head and Neck Cancer Center. I've known Lisa for about 5 years and I've enjoyed every minute of it. She is an amazing clinician, and I say that not because I'm one of her patients, but because I talk to some of her patients. She's also, we wanted Lisa to join the board many, many years ago, but she finally broke down and joined the board about 2.5 years ago. So we've had her skills and talent during all that time. And she's the president or co-president of her own company, in addition to her work at Moore's Head and Neck Cancer Center. That's Endo Education. The topic tonight is dysphagia and pain. And it's a topic that is near and not dear to my heart. I have chronic pain and periodically acute pain. So I'm really interested in this topic tonight. And at this point, I'm going to turn it over to Lisa for the next 45 minutes to an hour or so. So with that, Lisa, please take it away.
Okay. It's a pleasure to be here representing the National Foundation of Swallowing Disorders. I have known Ed and Elizabeth for a short period of my life, and yet the impact that the two of them have had on my professional growth is extraordinary. And so a shout out to both of them for their sound stewardship and leadership, leading this extraordinarily important organization forward. I thank you so much. So yes, I'm Lisa Blumenfeld. I'm a speech pathologist here at the University of San Diego, University of California, San Diego. I have the great pleasure of working both at our Center for Voice and Swallowing, and then I'm also one of the co-directors at the UCSD Moore's Head and Neck Cancer Center. So today we're going to talk about pain and dysphagia. And I know as speech pathologists, we think about those two symptoms coexisting in certain situations. But in most of the time, I can say from my experience, I don't really think of each of those conditions existing together synonymously. And what we're going to talk about today is how the combined effect of these two conditions can have a significant and profound impact on the disorders that we treat. And so hopefully, by the end of today, we're going to have a better appreciation of how pain, again, should be a critical thought process across multiple conditions that we treat. So talking about pain, I can speak for myself. I think, Ed, you said it very nicely. Pain is a condition that most of us will take extraordinary measures to avoid. You can see here how it's defined as the study of, it's defined as pain as an unpleasant sensory or emotional experience that's associated with actual or potential damage. Pain is complicated. It is complicated.
Lisa, I can't see your slide. Sorry to interrupt you.
Oh, you can't see the slide?
I can't see your presentation, no. Give us just 1 second and we'll get your slides up. I'm going to change the presenter mode back to you here and see if that shows a pop-up on your screen to share your slides.
Is it there?
Not yet.
Not yet. All right, it's loading. If you close out of your PowerPoint and then open it again, will it show up?
We can try that.
Okay.
Pardon us for a minute while we work through the wonders of technology.
Should be showing your screen.
Elizabeth? The only people that I see that can be presenters are you and me. So, do you have the slides?
I have an older copy of the slides. If you want to email those to me, Lisa, I can put those up. Or if your old deck is similar, we can use those.
So, so this isn't showing up still?
No, you're not a presenter.
It says you're the presenter. I'll change it back to mine as presenter mode here and turn it back to you. All right, so now everybody should be able to see my screen. Is that true?
Mm-hmm.
Yes.
Okay, let me share. Now, Lisa, do you see a pop-up on your screen that says show my screen?
We do. It says show a video.
Okay.
So maybe we should do main screen instead. I think that's what it is.
Yep,
Show
show
my
me.
screen.
Yeah.
There you go. Yeah.
There we
Got
go.
it?
There we perfect. All right. Thanks, everybody. You're good to go now.
All right. Okay, so what were we talking about? Oh, that's right. We were talking about pain. So, and that was a bit of a pain, but here we are back again. So pain, a very unpleasant experience. Most of us take many, many measures to avoid. Pain is actually a subspecialty in medicine. And in talking to a couple of my colleagues here at UCSD, who are pain management specialists, they say very clearly that the study of pain and the management of pain is so complicated because it's never a standalone symptom. It is always sort of cohorted with a whole host of complex conditions that straddle the emotional and the physiologic. And because of that, it becomes very complicated to sort of tease out what are the drivers of pain, and makes pain management extremely and extraordinarily complicated. And that's what we're going to talk about today, is that as speech pathologists, we manage so many conditions. And so what we're going to talk about today is how pain can be a thread that is sort of woven through some of these conditions. And quite frankly, as speech pathologists, if we understand the role that pain has in these conditions, then it really behooves us and allows us to be far more effective in our treatment and our management strategies. All right, so we're going to talk about chronic pain and dysphagia. And quite frankly, in my 23 years of experience, I never really thought about this topic at all. And yet when I received the topic, I thought, okay, that's going to be a 5-minute talk. Some people can't swallow pills and we're done. But no, it's actually far more interesting when we talk about how patients who live with chronic pain and have coexisting dysphagia, the ramifications of that are extraordinary. So folks that have these two conditions don't just have two separate conditions. The combined effect of them creates an extraordinary burden and challenge, again, that makes each of those more intense and more difficult to treat. So let's talk a little bit about chronic pain. Here's some information. This was shocking to me. So more than 100 million Americans experience chronic pain, and the large majority of them are elderly adults. The most common underlying etiology of chronic pain is lower back pain and neck pain. And look at the price tag that is associated with this problem. we're talking almost $635 billion are spent on managing this condition. And we don't do it very well, to be honest. That equates to $2,000 per human being living in this country. So as I mentioned, back pain, neck pain are the two primary drivers of this problem. And interestingly, what was found is that when we combine neck pain and back pain, guess what? These patients all of a sudden generate other comorbid conditions, and specifically more frequent episodes of significant psychological distress. But then going back and talking to chronic pain specialists, the sad and frustrating thing is that pain management historically and up until today is managed through on the back of solid oral dose formulations of opioids. We're giving patients pills to manage their pain. So as I alluded to, there can be a strong emotional component that is involved with pain and actually can drive pain. So it is not an uncommon co-presentation where up to 30 to 40% of people who have chronic pain have coexisting major depression. And this study by Carter was really fascinating. So what he did was he took normal, healthy people, don't have pain, aren't depressed, but subjected them to a whole host of scenarios. And these scenarios were created to induce feelings, intense feelings. So feelings of fear, feelings of pleasure, happiness, anxiety, and depression. And then they provided a pressure pain task. So they basically hurt them. And what they found was that those individuals that were subjected to stimuli that induced depression had reduced pain thresholds. They felt pain more when they were in a depressed state. So it doesn't alarm, or it shouldn't be, then it should make sense that the presence of depression in patients with chronic pain, they don't get better. It is incredibly challenging to meet their pain goals. These folks have poor performance status indices. They don't respond well to treatments, and the cost of treating them is exorbitant. So now we're going to layer another problem, and that's dysphagia. So we have pain, we have emotional distress, and what are we going to do? We're going to slap some swallowing problems on top of that. And that is where this condition is confounded exponentially. So patients who have chronic pain and dysphagia in the same, at the same time, those patients are found to have very poor pain control, so poor analgesia. These folks are found to have greater incidence of aspiration, as well as significant mucosal injuries to the esophagus. And it's not like this is a small number. 11 million people in the United States have CPD, or chronic pain and dysphagia. And yet, get this, only 25% of them actually talk to their healthcare provider. The people providing them and prescribing these pills, only 25% of those patients discuss the fact that they can't swallow the pills. So that leads them to then take matters into their own hands, and they alter these medications. They chew them, they crush them. They think they're doing the right thing. It seems intuitive. But many of these formulations, especially those that are designed to be used over time, that is not the intent or the design of that medication. And this can exacerbate physiochemical incompatibility within the drug, as well as between that drug and other drugs, which can make that particular medication completely ineffective or toxic. We just held our laryngectomy support group yesterday, and one of the members was talking about having dysphagia shortly after his laryngectomy and took a medication for pain, crushed it and swallowed it, and actually suffered from hallucinations for a couple of days, and just said it was one of the worst experiences of his life. So this is a great example of, Erin, can you help me here? Actually,
Sure.
oh, right here. So this is a great example of, here it comes.
Go ahead.
Lisa, we've lost your sound, or I've lost your sound.
Lisa, I forgot to say, when you play videos, your audio will stop to play the computer's audio. So everything you said
Gotcha.
during that video was missed, but if you can replay that, that would be great. Or re-say
No
what you were
problem.
saying during the video.
Just a good example. So everybody saw the video, but it's just a very good example of a patient that just simply is unable to swallow, and this captures it nicely. This is another wonderful example. I'll talk about it first, and then you guys will be able to actually see. In our head and neck cancer center, all of our patients are seen by a speech pathologist before they start treatment. And this is an individual who came to us, unfortunately, has very severe advanced recurrent metastatic head and neck cancer. And he came to us really hoping to take part in an investigational trial that required him to be able to swallow a pill, a specific type of chemotherapy agent that couldn't be crushed. It couldn't be compounded into any sort of liquid formulation. And so the medical oncologist brought him over to my clinic and asked me to take a look at him and see if that was able. So we'll do a little task in this scenario. I provided him with some applesauce and a peach. And so I'll go ahead and now mute myself and show you the video.
So click this, and then from here.
What do you think? You want to try that little bit of peach?
Yeah, I would try.
Okay. You're going to have to do this for me. Hold your breath while you swallow like 4 times in a row. Can you do that?
Yeah.
Okay. Hold your breath. Let's try that.
Swallow it whole.
Okay. Turn your head, chin down, hold your breath tightly. Swallow, swallow, swallow. Cough hard. I think I just saw it. Did it come back up in your mouth? Yeah. It's in your mouth. You want to try it one more time? Chin down. Swallow, swallow, swallow. Oh. And cough it up if you need to.
All right, so I think everybody got the picture. Unfortunately, then this patient was unable to participate in that trial, but think of the stakes. If this patient was provided this regimen of treatment and simply could not get that pill down. So chronic pain and dysphagia, this is a staggering finding that those patients that have both conditions actually have a 300% increase in adverse drug events as compared to those that do not have dysphagia. So a lot of people will say, well, wait a minute, why don't we try those patches? That's what some folks have asked me. And transdermal routes can be very effective. There's pluses and minuses on both sides. Patients can see reduced peak trough fluctuations. There's a reduced dosing burden. There's a first pass on the liver, which is great. They tolerate it well. But on the negative side, there can be local irritation at the skin. The absorption is unreliable based sort of on the topography of the skin. Heat can actually modify absorption. There is currently no deterrent for abuse of these medications, and they are ridiculously expensive. So the good news, and this is exciting, is that there are some new formulations that are in clinical development and some that are actually available. And all of these are dysphagia-centric. So they are designed to be manipulated without, and these are time-release medications that can be manipulated in such a way that our patients with dysphagia can actually see the benefit of the medication and yet be compliant and which is compatible with their swallowing function. Some of these tablets are chewable. They can the capsules can be opened in the forms of sprinkles or pellets that can be placed on applesauce or yogurt. And so these are 3 of the medications. We're actually working on getting these at the cancer center. And again, these are all opioids. And the Deturex, actually the one at the bottom, has some wonderful deterrent benefits as well. So BEMA
Back
is...
to your presentation. We can only see the video right now. Sorry.
Is that still the case now?
Still just see the video, the end of the last video that was played.
How about now?
We can only see Lisa now. You go into the sharing box and then the show, and then there we go.
Got
Starting
it?
almost. Not quite. It changed, but not to the PowerPoint. I apologize for this. GoToWebinar just changed the settings on their platform, so switching between the videos and the presentation mode is different.
Yeah, it's just, let's see. It's just spinning, 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 trying to go back to the main screen.
Okay, I'm going to turn the presentation mode over to me, and then I'll turn it back to you to see if that helps with it.
Yep.
All right, so you should see a pop-up that says show my screen. All right. And then if you go under the sharing window, it should have that big play button that says show with a drop-down box.
Yeah, it's just spinning.
The problem is it's just not spinning.
Oh,
It's almost as if when we switched it back,
okay. Solutions. Either if you want to sign out and then sign back in, I know that's kind of a hassle to do that. You could do that. Or if you want me to try to load your slide deck, I can do that as well.
Still spinning. I think we should.
yeah, when we switched from one to the other, it's just stuck.
Okay.
Elizabeth, if you have the deck and can you put it up, maybe we should head in that direction.
That's good. Let's pull that up.
Let me go to activity monitor. It's not responding.
Give me just 1 second to find it here. All right, just downloading.
Lisa, while we're waiting for this, could you talk a little more about the video that you just showed with the peaches and what that patient was was experiencing.
I think Lisa signed out to sign back in. I apologize, everybody, for the delay. We should be back on within a few minutes. If everybody wants to take a quick break, we'll be back soon.
So do we just sound check? Yeah, can you hear me?
Yes, we can hear you, Lisa.
Can you hear me? Show my screen? Yes?
Yes, show my screen. Okay, and then we'll go back to the PowerPoint. See if we still have that open. And can you see her screen now?
Are you able to see the screen? Yes?
Yes.
We're good?
Okay, go.
I apologize. Okay, wow. The wonders. Seriously, the fact that this is called the pain talk is pretty darn funny. Okay, so we were talking about the incidence of pain. We're talking about the emotions associated with pain. We're talking about dysphagia in pain. We talked a little bit about patients that cannot swallow pills, showed a video, another one with head and neck cancer, and then talking about adverse drug effects. And here we are now talking about new formulations that are in clinical development. So if we skip this slide, it's important to see that there are these new formulations that are available that are very sensitive or centric to patients with dysphagia. They could be chewed, the capsules can be opened, they can be sprinkled, and they absolutely can go through a feeding tube. So this is pretty exciting because no longer do patients really have to, like I say, take matters into their own hands and disrupt what could be a very potent formulation because they simply can't swallow the pill. So these are 3 of the medications that are now available. They are all opioids, and they can all be manipulated. So BEMA is a product, a pill that has a polymer film that can be chewed, as well as the oxycodone, naltrexone, and Deturix, which are extended time release tablets. They're opioids that can be opened, they can be crushed, they can be chewed, and they can, as I said, be flushed through a feeding tube. And this is what they look like. So really cool for us as speech pathologists to be able to go to our providers and say, hey, Mr. Jones can't swallow a pill, so we're going to need to think about some sort of formulation that's going to allow him to get pain relief and yet not cause him to aspirate or have some other problem on top of his chronic pain and dysphagia. All right, so something that's a little bit more familiar to us is odynophagia. These folks come into our office all the time. These are individuals that say it hurts when I swallow, there's random pain. And what we come to find out is that there are intrinsic factors localized to the throat and the swallowing mechanism that can trigger odynophagia. And then there's extrinsic factors. And so we're quickly gonna highlight a couple of those. When we talk about extrinsic factors, without question, the most common issue that we see are disorders that are localized to the esophagus. So achalasia is a condition of failure of the esophageal sphincters to relax. And this can cause significant and profound pain in patients. Oftentimes they complain of pain, solid food dysphagia. These folks have weight loss. So this is a really, really significant condition for us to sort of have on the radar. And another reason why it's of critical importance that we test patients with a placebo pill and we screen the esophagus, watching it migrate all the way through the upper digestive tract down into the esophagus. I can't count how many times we have picked up achalasia during one of our fluoroscopic swallowing studies. Another is diffuse esophageal spasm. So this is a little bit different. These folks tend to come in and say, I am having profound pain with swallowing. Well, when does it happen? I don't know. It can happen once a month. It can happen once a week. What does it happen with? Well, it can happen with anything. It could happen with my spit sometimes. And what do you do about it? Well, I typically just will kind of wait and relax, and then it sort of goes away. So this is caused by a replacement of normal peristaltic activity with non-peristaltic, non-effective contractions that can be extremely painful to patients and very disruptive. Extrinsic conditions leading to severe pain with swallowing can include folks that have all sorts of inflammatory conditions, autoimmune conditions, esophagitis. Whenever patients go through a formal workup and everything looks pretty good, I'll do the esophagram, and I very commonly will recommend an EGD or a transnasal esophagoscopy to try to get the bottom of what is causing patients all of this pain. And certainly we have those incredibly interesting visits where patients will come in and complain of severe pain, and we do an endoscopy, and you know what? You know, your throat can be a treasure chest. There are some amazing things that can be pulled out of there. So no talk can be complete without some fun pictures. So this is a rock lodged in the upper aerodigestive tract. We got a toothbrush. We got a pill, but it's still in the wrapper. And we have a penny. So a whole host of things can sort of make their way down there. And I always wonder, what were you thinking? But you know what, it still happens. And it makes it a really interesting day. So moving on. This is a really interesting study that looks at esophagitis and what can happen when we swallow pills. So, you know, a lot of our providers, a lot of physicians really don't appreciate the fact that pills can be a problem, not just in the fact that they can't swallow them, but folks that have altered motility can find these pills lodging along the soft mucosal lining of the esophagus, adhere to it, and cause some significant degradation and injury to this, which can be incredibly painful, destructive, and dangerous. So it's really important that we understand this condition and we're very sensitive to it. I'm a little reticent to play this video.
Play it from there. Play it from there.
Play it
yeah.
Like this? Yeah. So this is a transnasal esophagoscopy, and you can very clearly see how there's this circumferential pattern of nastiness, for lack of a better term, that is associated with this chronic esophagitis, which was induced by pills. So Peter Belafsky and his colleagues up at UC Davis finally came up with a tool that is specifically sensitive to the presence of pill dysphagia. So it's the first reported patient-reported outcome tool that allows us, the clinicians, to get a sense for can patients swallow pills. There is one pill question on the EAT-10, but it's become such a significant problem that I think it's perfect timing to have a really nice 5-item PRO that really is sensitive to that. So responses are gleaned from patients, and a cumulative score of greater than 7 indicates a problem. And this is so important because, again, this sends a message to us as clinicians, as speech pathologists, and then it's our job. We have to go advocate for these patients. We have to then go back to their PCP or referring providers and make very certain, make it clear that once we identify that they have a problem, we confirm it's a problem, then we have to let their providers know there is a big problem, and we either need to send them to a compound pharmacy where they can have these medications formulated in a liquid, or we provide them with some pill that can be manipulated. So a wonderful new tool that I highly advocate for speech pathologists to integrate into their workup with patients. So intrinsic factors. We're really just going to talk a little bit about head and neck cancer. So without question, sore throat and significant pain with swallowing is the most common presenting symptom of carcinoma of the supraglottis. And interestingly, a lot of our patients that come through for their initial visits, when we talk about how this all started, they said, yeah, I had pain with swallowing and I had ear pain. And I've never really quite understood this coexisting nerve pain with the odynophagia. And that's because there's a small nerve that branches off the vagus that actually innervates the supraglottis and migrates up to the auricle. And so it can, in fact, trigger this very interesting combination of painful swallowing with very, very significant deep ear pain. So this is a patient that came into my clinic and complained that he likes to go to In-N-Out Burger on Tuesdays and Thursdays. And when he orders the double, he notices that it gets stuck. And then when he tries to swallow it, it's achy. And by the end of the burger, it hurts. So that was his symptom. I'm serious. That's exactly what he was complaining of. So he came into my clinic and we popped the scope in, and let's just say, big bite, big burger, big tumor. So this is a T4 squamous cell carcinoma of the base of tongue that actually migrates all the way down to the vallecula. On imaging, we can actually confirm that it articulates with the hyoid bone and adheres completely to the lingual surface of the epiglottis. Big tumor. Only complaint is pain. So that's a really good segue to dysphagia, pain, and cancer. Head and neck cancer is what we're really going to talk about. So as the director, one of the co-directors of the Head and Neck Cancer Center at UCSD, I have to say it's been such a pleasure to spend and invest so much of my time managing these patients. And I thought I knew a fair amount about dealing with head and neck cancer, and I created my workflows and dealt with dysphagia and speech. But what I've come to realize that if we don't address pain before, during, and after treatment, we are completely missing the boat. We have to make that a chief consideration. And so we have taken great pains and steps to ensure that pain management is really a critical part of our multidisciplinary care pathway all the way through. There's really no shortage of information that really highlights the critical value of things like eat and exercise, keep them off a feeding tube, keep them well nourished. But boy, we have to be realistic in what we're asking these folks to do. And I can tell you now with a fair amount of experience, and I think many of my colleagues will agree with me, that if we don't mitigate the pain problem, we will be very hard pressed to stop this sort of domino effect of what happens when patients stop eating. If we can't manage their pain, then these folks are going to stop swallowing. They are going to have rapid accelerated weight loss. They are going to have depression, and along with a whole host of other conditions that will certainly lead to a feeding tube placement, and again, a whole host of negative outcomes. So as speech pathologists, it's really great to say we gotta keep them eating, keep them swallowing, but if we're not an active participant in that pain management process, then quite frankly, we really are missing the boat and really have unrealistic expectations of our patients. So what's driving the pain? So those of us, again, that are working with these folks get a really good opportunity to see candida or yeast. So head and neck cancer, unfortunately, has a couple of conditions that really seem to push that domino with regards to elevated and exacerbation of pain. So yeast is largely caused by the conditions that are involved with combining chemotherapy and radiation. So those folks that receive radiation with chemotherapy, the chemotherapy is really designed to be a radiosensitizer. It's designed to help the radiation pack a greater punch and kill the cancer. Unfortunately, these patients have a greater incidence of candida and a greater incidence of mucositis. And Singh and his colleagues really looked at candida and mucositis and found that these oral fungal infections really piggyback oral mucositis. The worse the mucositis, the greater the incidence of candida. And we've all encountered those patients and they're swimming along and holding their own and doing well. And they come into your clinic and they say, it feels like I'm swallowing glass now. I can't do it anymore. And that's usually because they have an acute thrush infection or fungal infection. Not all, I thought that there was just Candida albicans, and this is interesting that non-albicans Candida is actually more common in head and neck cancer patients than Candida albicans. So it really supports the fact that if we have an opportunity to mitigate this and reduce the incidence and the severity of these types of problems, then our chances of keeping patients their pain managed and eating are far greater. Without question, mucositis is the most complex condition confounding PO intakes and the whole pain equation. So mucositis is a very common complication of chemotherapy. Again, it's when chemotherapy is added into the mix. It's where patients have this extraordinarily painful breakdown of the mucosal lining of the oral cavity. It can cause these horrifically painful ulcers and really has been found to be the #1 cause of why patients stop eating. And I behoove, again, all the speech pathologists, another take-home message: get a good pen light, get a headlamp, get some way of looking into your patient's mouths every single time they come in. Sometimes it's as simple, especially in folks that have ipsilateral disease, meaning it's just contained to one side of the mouth. Utilize what isn't damaged. Something as simple as just tilting their head to the good side to not expose food or liquid to that horrible mucositis can really be a game changer for these patients. So frequently, every single time they come in, take a peek and look inside of the mouth. Now, this is, I think, something that's very, very exciting. There are some new novel treatments that are coming out for mucositis. The goal being, #1, to hopefully delay the onset of mucositis and decrease the severity of mucositis. If we can do that, we can keep patients swallowing longer into treatment. So glutamine is a product that has been trialed and used in folks, and 53% of patients in one study actually didn't develop mucositis until the 5th week. None of those patients in the glutamine arm of the study actually required a feeding tube to be placed. Turmeric, I think, is quite exciting. We're actually getting ready to launch a clinical trial at our institution looking at turmeric rinses for patients. It's a very rigorous protocol. A lot of this information comes from colleagues actually in India and more of an integrative medicine spectrum and realm, but found that patients who do these recurrent high dose levels of turmeric, these rinses multiple times per day, have a dramatically reduced rate of mucositis. And I can tell you anecdotally, those patients that have come through my clinic performing this regimen, and it is quite a regimen. These folks are rinsing their mouth multiple times per day, have pristine oral cavities that seem to be almost completely spared for mucositis. So very excited to explore that a little bit more. Aloe vera has been looked at to reduce the grade or level of mucositis. And then there's the low-level laser light therapy. I myself have not had exposure. There's a company called Thor. There's some good work being done at the University of Pittsburgh using this low-level laser light as a vehicle to potentially reduce and or prevent mucositis in patients undergoing radiation and chemotherapy. But this is probably my favorite recommendation, and I don't know if Heather is out there. If she's not, Heather Starmer has really provided such a gift to providers like me and head and neck cancer patients in doing some really good work looking at the effect of neuromodulator gabapentin on swallowing and pain during and after chemoradiation. And so this is actually a retrospective study that she did and looked at those folks that received gabapentin as their primary source of pain management as compared to those that were receiving primarily opioid-based treatments, and found that those who were treated with gabapentin actually used their feeding tube later. Their feeding tubes were removed earlier, and they had very specific areas of improvement that were confirmed on fluoroscopic swallowing studies. They had reduced penetration aspiration scale scores, and they enjoyed a more normal diet. And I can tell you that the physicians and providers that I have been able to convince or talk to about using this regimen have come back to thank me. I can also tell you that patients who get on this regimen and try to come off of it too abruptly will report severe refractory pain. It is very effective. Patients can take a very high dose, and oftentimes we recommend taking that high dose before bed to reduce some of the side effects from the medication. Sometimes it's just as simple as printing off some of these articles. If we don't feel comfortable, talking about pain management outside of our scope, just slide it across the table, pass it to one of the physicians and let them know. I've also had some patients more recently not being able to tolerate gabapentin and have tried a similar product called Lyrica that have seen some similar benefits. So, okay, we have another layer now to add on this whole confounding process that invites enormous challenge. So we have pain, chronic pain, we have depression, we have cancer, and now on top of that, we have malnutrition. So malnutrition sort of invites a whole host of additional problems that really mitigate and confound management of these patients. So Silva looked at 222 patients and looked and investigated the incidence of pain and sleep, malnutrition and sleep disturbance. And what they found is that those folks that lose a lot of weight, they aren't sleeping well, and that triggers then a apparent change in serotonin production, which is a biomarker, of course, for depression. And it shouldn't really surprise us again. So if our patients are not able to swallow, their pain isn't managed, they're going to become malnourished. And this not only is going to cause a whole host of, again, disruptions to their quality of life, it also is going to reduce their pain thresholds as well. So these folks are going to report greater poorly managed pain. So it's really no shocker, shouldn't be a shocker to anybody, that post-traumatic stress disorder in head and neck cancer is actually the highest of any disease site. And again, this is an interesting study that was done by Poslesny back in 2014 and found that head and neck cancer patients had true bona fide PTSD. And this was scores in regards to anxiety and depression really revealed these patients are dealing with tremendous amplified levels of anxiety. And a lot of it has to do with this anticipation of having to eat. So these are some quotes from patients of mine that have to do with this exact fact. You dread it, you dread have something to eat, the fear, the pain, they're unbearable. I went to church and I was terrified of going to communion. It just hurt so much going down. So these are the daily experiences of these patients. And remember, this journey of head and neck cancer treatment isn't a day or a week or a month. These patients can languish in this condition for months and months and months. And I just have to throw out there that actually the rates of PTSD in the caregivers or spouses of head and neck cancer are actually higher than in patients themselves. So it really makes us ask these questions. And there isn't any bona fide research science behind this, but it makes me think, are we creating new motor pathways with head and neck cancer, this persistent barrage of pain, emotional distress, malnutrition? Are we redefining, are we recalibrating the way we swallow? So is there a true disruption in the oral and even pharyngeal phase of swallowing that has to do with these manipulations and these experiences that patients have to deal with through this head and neck cancer journey? And so that kind of takes us now to psychogenic dysphagia. And so I happen to have a profound love for this population. I enjoy working with them. And yet what I'm finding more and more is that a lot of the patients that are coming in with a diagnosis or suspicion of psychogenic dysphagia from their referring providers actually have some organic cause or issue that is driving this dysphagia. So this sort of supports that. Johns Hopkins went and looked at a bunch of cases of folks that were actually admitted with psychogenic dysphagia. And when they went back and actually did a thorough reevaluation of these cases, they found that more than half of them actually had an organic cause. Which leads me to talk about, this isn't a typo, muscle tension dysphonia, it is muscle tension dysphagia. So this is an article, quite frankly, that I just read a couple of weeks ago and really found to be quite fascinating. And it definitely is somewhat intuitive and made me think about possibly having seen this multiple times in my career. So this study and this notion of muscle tension dysphagia was published by Christina Kang and her colleagues at the Mayo Clinic in Arizona. And what they did is they went back and looked at almost 600 fluoroscopic swallowing studies. And what they found, they ruled out, or they identified 67 patients that had a normal exam, but had this complaint of odynophagia, complaints of food sticking. And when they actually went back and sort of ran them through sort of a voice evaluation, they found in terms of palpating the larynx and doing an exam that these folks had very prominent laryngeal and extralaryngeal muscle tension. So they were able to convince 13 of them to come in for behavioral voice therapy. And they performed traditional voice therapy techniques, including massage, as well as resonant voice therapy. And all 13 of these people reported full resolution of symptoms. And I read this article on a Monday night, and Tuesday morning, I do fluoro, and this patient walked into my office, walked into the fluoro suite, and she was a 68-year-old female coming in with a 3-year history of odynophagia, globus. She had also some GI symptoms, and she was so impacted by this condition that she downgraded herself to just a full liquid diet. So she actually went out and had a full GI workup. She had an EGD, she had motility testing, manometry, esophagram. None of those were abnormal. There actually was some bacterial overgrowth in her gut, which was treated, but really nothing strikingly wrong. So of course, we tell patients what we're going to do during the fluoro study. And I said, well, listen, I'm going to give you different textures, and I really want you to tell me if you start to feel any of these tight, painful symptoms. And so I start off with, and I specifically asked her if she had had any voice changes, any dysphonia, and she vehemently denied that. So started off giving her liquids. I asked her, how does it sound? How does it feel? Good. Went on to puree. Any problems? How does it feel? Good. Went on to mechanical soft. Having any problems? How does it feel? Good. Went on to solids. How does it feel? I'm feeling it now. Her voice changed, and she started to have symptoms. So when I asked her about it, I said, does this happen? Do you notice, do you talk during your meals that your voice changes? And this light bulb sort of went off, and she said, yeah, I guess, maybe. So I was able to convince her to come back and do 2 sessions of behavioral voice therapy. I did things a little bit differently in integrating heart rate variability biofeedback. So talk about that in a quick sec, but integrated that. And let me tell you, this was incredible. She had complete resolution of her symptoms. She went back to eating sandwiches, steak, pretty much anything after going through a home program of biofeedback and 2 sessions of therapy. So heart rate variability biofeedback is a wonderful tool. It's a great modality. This is sort of a picture, and I'll just highlight really quickly the information that we get from it. So what we're trying to do is actually tap into the autonomic nervous system, and specifically trying to reduce or diminish the activity of the sympathetic nervous system, while at the same time trying to amplify the activity of the parasympathetic nervous system. And we do that through a host of monitoring signals that include monitoring heart rate, respiratory rate, skin condensation, and skin temperature. And it's basically all titrated through their breathing. So I'm going to show you a little video of how it works. But what you're going to see is there is a little red, green, and blue sort of bar. The red indicates their sympathetic nervous system, which is their fight or flight reflex. The green is the rest and digest, or their parasympathetic nervous system. So the goal is to create these green peaks, and then finding what rate of breathing is going to stimulate that. And what you'll see is initially I'm going to just have her breathe. She can't see the screen. And we're going to get an idea of what frequency is going to work well for her, and then turn it around and let her try to model breathing as I set it. And you're going to see that she's actually able to then calibrate her breathing to that cue. Okay, Gina, just go ahead and breathe normally. Okay, now I'm going to have you go ahead and take a look at the screen, and I want you to watch the green ball as it's moving up and down, and I want you to pattern your breathing both on inhalation and exhalation. I want you to follow that natural curve as it goes all the way up and all the way down. Just go ahead and follow that curve. Inhale and exhale. So you can see that she was able to calibrate her breathing in such a way that provided a very nice visible peak. So we then send these patients home with a little app that they download onto their mobile device, and they are able to then practice that at home. I can't say enough. We're actually looking at heart rate variability biofeedback for numerous indications in our clinic, and hopefully we'll get to talk about that a little bit more detail another time. So in summary, gosh, we got through this. No more glitches. So pain and dysphagia, yes, they're distinct, they're separate conditions that carry their own set of challenges in managing. However, when we put them together, they really can have a very severe and a very, very exponential impact on function. Chronic pain conditions are a big problem in our society. They're becoming more rampant, and they are expensive. It is critical for us when we see folks that come in, we have to ask them about coexisting dysphagia. And we specifically have to probe their ability to swallow pills as well as other textures. And we have to share that information with referring providers. Pain management has to be germane to the management or the development and the implementation of a multidisciplinary head and neck cancer program. We simply cannot ask our patients to do things that they are simply incapable of doing because their pain thresholds are unbearable. So I think that's sort of a newer concept for me in my career, and I would definitely advocate for that. And absolutely, it is our role and our job to be a spokesperson and a liaison and advocate for patients who have dysphagia and have pain, and really use our expertise to help them manage those conditions, but also help them communicate and interact with their providers to be able to receive and tolerate formulations that provide them with that all-important relief from pain. So with that, I will gladly take some questions. Thank you for being so patient with all of the technical glitches, but happy to entertain any questions.
So thank you, Lisa. I'm going to start out by saying that HRBV, while I was watching it, felt very meditative.
That's the point. Yes, actually, we have patients before they go to bed. It's a wonderful way to help folks kind of relax before I say, you got to do your practice anyways. Set it for 8 minutes, put it by your bed, and about 7 minutes in, you'll be snoring. So it's a great tool.
So here's a question that came in about 15 minutes ago. So think back. Does mucosis only occur with oral cancer or chemotherapy for any cancer?
I'm sorry, say that.
Does mucositis only occur with oral cancer, or is it prevalent in chemotherapy for any cancer?
Great question. So actually, mucositis is a common condition in patients receiving all types of systemic treatments for a whole host of cancer diseases. So if patients are getting chemotherapy, they are very likely to get mucositis, whether it's for treatment of esophageal cancer, breast cancer, lung cancer. Mucositis can be an accompanying symptom. It just happens to be more prevalent in head and neck cancer patients because the environment of the mouth or the throat is it is a breeding ground. It's dry. Folks aren't swallowing. Acid levels are high. So it is just a prime opportunity for the development of not only mucositis, but coexisting candida.
Thank you. I really butchered that word, but you had it. So another question, what program are you using for heart rate monitoring?
So we use a program, it's through biomedical, Aaron, is it biomedical engineering, the HRBB, we've had it for a long time. I think it's called biomedical engineering something. I'm going to have Aaron look it up and I will say the name of it. But it is a wonderful tool. I think the total cost of the system is what, about $2,500 by the time you have a computer, a laptop, as well as the signals box, which allows you to track heart rate, respiratory rate. And so I think the total cost is about $2,500. I absolutely love it. I use it during my head and neck cancer support group. We're looking at it with cough, intractable cough. So I believe there's a role for it in a whole host of conditions. But again, I'll get you the name of it in just a moment.
Okay. Another question. Some of our patients ask for biotin drops. However, I don't see any benefit for more than a few minutes. What is your experience? And before you answer that, I just want to say that biotin is not a sponsor, but it is a favorite product of mine.
Well, so this is what we do. You know, we got to make lemonade. We got to help our patients make lemonade with with the lemons. I mean, obviously our first goal, or the goal, the golden chalice, is to eliminate the onset of mucositis, or to at least curtail it or diminish mucositis to where it's not such a tremendous burden to the patient. So, you know, that's obviously our primary objective. But the challenge is that's not very commonly the case. We have patients take measures to try to prevent it. We have them rinse with water, baking soda, salt. We find that to be very helpful. But once they have it, we have to help them manage it. Biotin, there's a whole host of products out there that really are more designed, in my experience, to deal more with xerostomia or dryness, which, as Ed can probably speak better than myself, can persist sort of indefinitely after treatment due to damage to the salivary glands. So really what we do during treatment is we provide local analgesia that can come in the form of like magic mouthwash, which is a lidocaine-based medication. It's mixed with all sorts of things. I think milk of magnesia, lidocaine, there's something else in it. But some folks will literally do that. And it's sort of a Band-Aid. I mean, it literally just numbs up the mouth so patients get some comfort and they can get some food down. So that is an option. Again, it's just really a Band-Aid. And then longer term, folks that are really suffering from persistent discomfort because of dryness or xerostomia, some of those products, some have Biotin, there's Xylomart, there's products that have xylitol, Xylomelt. So there's a whole host of products that are used for patients long term to help manage those conditions. And I just got the name of the hardware and software that we use. It's called J&J Engineering. If you guys can see that, but J&J Engineering. And anyone, my email is right there on the last slide. You are welcome to email me. I'm really a strong proponent of this system. It definitely is more in its exploratory phase with regards to applications in speech language pathology, but I have a feeling we'll be seeing it more and more. As I said, it's just a great way to sort of manage stress, manage anxiety. I actually believe if we tested patients' pain levels before and after HRBP, pain thresholds would actually be greater. They'd be able to tolerate more pain in a more relaxed state.
Thank you for that. This question has to do with patients who are unable to swallow pills. And the question is, how do you go about discussing with the physician that the patient is now needing a change of medication due to their issues with pill swallowing? So do you have techniques?
Yeah, so I can appreciate that in some situations, if you don't have diagnostic equipment, I really think it's a pretty candid discussion. Patients, I trial them. I'll sometimes use, like I said, a little piece of a peach. I'll do different probes. Obviously, when we're doing fluoro, we have our placebo pill. But I do remember having an instance at another institution, and I had a physician that just simply absolutely would not agree with liquid formulary, and I just burned a copy of the fluoro study onto a stick drive and I played it for him. So, and then there's of course lots of great information about pill dysphagia. So I think if need be, I think having physical evidence can be helpful. But I really feel as speech pathologists, that's our job. Our role is to be able to identify what patients can and cannot swallow. That's why doctors are ordering it. So I think, sometimes I've had to say, look, this is my opinion. This is my role. This is how the assessment went down. They can't swallow a pill. So I have to say, thankfully, I don't encounter too many issues. I have had some challenge with the Gabapentin and getting people to sort of believe and take on that protocol. But I'm happy to say that just with time, folks are kind of catching on, trying to get away from the opioid treatments and maybe using them more for breakthrough pain but using gabapentin as really the primary driver or component of the pain management program.
Can you repeat the information that you provided on the tool being used by Dr. Peter Belaski for pill dysphagia?
The pill 5, you want me to find that slide? Sure.
Yes.
It was presented at COSM. He was kind enough to send it to me. Oh, there it was, right there. So 5 simple questions. Pills stick in my throat, pills stick in my chest. I have a fear of swallowing pills. My problem swallowing pills interferes with my ability to take medication. I can't swallow my pills without crushing, coating, or using other forms of assistance.
Can you provide us with a reference that, let's see, can you provide us with your reference? I'd like to read up on the novel treatment for mucosis.
Sure. Yeah, there's actually some really, really great. So you have, there are some of the names. I can get you, I can't see part of the screen here, but I can get you the information on that glutamine study. But there is a, if you look up glutamine in head and neck cancer and mucositis, you should be able to pull it up. But it's a pretty good study. And there are others. So I think we're going to be seeing more as we're really trying to steer away from opioid use and utilization. I think we're going to see more and more of these types of studies that are trying to avert or avoid the necessity for those types of pain medications.
And for our participants out there, if you have questions or that we haven't gotten to, or you would like a copy of a slide, please send either Lisa, an email to Lisa or to us at info@nfosd.com, and we'll get you that information. Another question, what recipe do you use for turmeric grits?
So this is not my recipe. I would look at that publication. It actually, I believe, uses capsules, organic capsules, so that you really can be very accurate with the amount of turmeric that you use. So I would pull up that study. In regards to the rinses with the baking soda and the salt, that's 8 ounces of water, a 1/4 teaspoon of baking soda, and a 1/4 teaspoon of salt. The study that we will be doing, we have not actually fine-tuned or confirmed the turmeric utilization. It has to do with how this will be dispensed from the pharmacy, but we are likely to also be using a capsule form that folks will open the capsule just so that we know that we have consistency in the turmeric product as well as the dosing of
it. Is the pill 5 assessment available from the researcher or available online?
I don't know if it has been published. I'm happy to ask Dr. Belawski. Again, it was presented and he was kind enough to allow me to share it. I'm not certain if it has already been published in a journal, but I would certainly be on the lookout for it, and I'm happy to ask him if it is available now online, the whole article.
Have you seen pain, acute pain in head and neck cancer patients that have led to even to larger problems such as a stroke?
No, I can't say that I have. I can say that really the issues that we deal with regards to pain sort of then kind of trigger conditions in the realm of emotional distress, nutritional compromise, obviously swallowing dysfunction. So those are primary the realms. You know, it's so critical though that we are always asking our patients about pain. I've had the unfortunate experience of having patients come in and talk to me, and you know, sometimes during their surveillance visits, physicians don't have the time. They might not pop a scope in there, but we really need to probe and see how they're doing, because sometimes the emergence of new pain, unfortunately, can be a sign of recurrence. So, or something like osteoretinal necrosis. So something that is extremely dangerous and needs to be managed. And again, just another wonderful reason for us to be very sensitive and specific when we talk to our patients about pain with and without swallowing.
That is all the questions that have come in, I believe. And so, Lisa, I want to thank you for volunteering your time tonight. This has been terrific from my perspective, other than our technical difficulties. They were stressful for me, so I can't imagine how stressful they were for you.
It's all good. It's how we roll, Ed, right? We just roll with it. Feel the pain.
So one more question, and then we're going to turn to a closing slide for myself. Do you ask patients to quantify their pain?
Oh, absolutely. We have to. That's part of our documentation. And not only do they quantify it with a number, but they have to describe it. So we have them describe it. We have them localize the pain to a specific area. So we have to include that information on every single note. And again, it's more like that's my point in all of this is we have to go beyond what's your pain level, 0 to 10. It's really got to be far more specific than that. Tell me, when does it get worse? What makes it worse? Where is it localized to? What makes it better? And that is really sometimes the great entrance to potentially uncovering something that is a problem or something that we can help out with.
Okay. So Lisa, with that, I'm going to close with 1 or 2 slides. And again, thank you for your time this evening.
My pleasure.
So we had another webinar scheduled for about a week and a half from now. And it was titled, Do We or Don't We? And it was around dysphagia and end-of-life decisions. We had to postpone that because of a family emergency. We're hoping to reschedule that in the September timeframe. So just wanted to get that news out. And so I want to thank everyone for participating. And if you did have a question that we did not answer, please email us at info@nfosd.com. We do follow each webinar up with a questionnaire. It takes literally a minute to fill out, but it provides us with feedback we need to go forward. And we hope this was valuable for you, either as a patient or in your practice. And we look forward to you joining us again for our next webinar. So thank you, everyone. And Lisa, huge thanks for you for joining us tonight.
My pleasure.
Okay, bye-bye.